Now I call upon Dr. Pappa for her talk, Viral Retinal Mysteries.
So from the anterior segment, now move on to the posterior segment. So let us see some of the common viral retinal lesions. The most common being the herpes virus retinal lesions. It can produce acute retinal necrosis. It can be produced by both HSV and HZV. Usually seen in immunocompetent, and 70% of cases are unilateral. The retinal necrosis starts from the periphery and spreads in a circumferential manner and causes occlusive retinal arteritis, and severe vitritis will be there. The prognosis is good if you treat early with intravenous antivirals, but 70% of the cases develop retinal detachment. Next is progressive outer retinal necrosis. The difference is that it usually comes in immunocompromised persons. Both HZV and HSV can cause, and usually it affects the posterior pole and involves the macula. It has got a fulminant course and causes bilateral blindness and no vitritis because it is immunocompromised patients, and prognosis is better with intravitreal antivirals, not much response to systemic antivirals. So this is the difference. So you can see in ARN starts from the periphery, but PORN is mostly in the posterior pole, and more of vitritis and hemorrhages you can see in acute retinal necrosis. So this is a table which shows that acute retinal necrosis is usually associated with anterior uveitis and scleritis. So patient may have pain also, and it is it causes occlusive vasculitis. The other one is no vasculitis. Next is the cytomegalovirus. It's usually seen in HIV patients if the CD4 count is less than 50. And nowadays the incidence is low because of the effective antiretroviral therapies. Mainly 3 types. It can cause frosted branch angiitis, that is phlebitis, granular type, and necrotic. Necrotic is said to have a more aggressive course and it can produce retinal necrosis and detachments. Granular is the least aggressive form. The differences between ARN from CME is, again, ARN is immunocompetent and affects the peripheral retina, and it is occlusive arteritis, while in CME it is more of phlebitis, and vitritis is more in ARN, but no vitritis in CMV, and less hemorrhages compared to CMV in AR. Epstein-Barr virus is not a common virus, but it can produce an ARN like acute retinal necrosis like picture. It can produce panuveitis and frosted branch angiitis. Now the COVID-19, the retinal lesions are seen in infected persons as well as post-vaccination. The common presentation is it can produce a multiple evanescent white dot-like syndrome. So you can see the white dots distributed more in the peripapillary area, and it is usually unilateral. It is due to inflammation and response to steroids also. Because of the hypercoagulability in COVID patients, the major vascular accidents are common like CRVO and CRAO. And even vaccinated individuals can have these kind of vascular accidents. So the third picture shows a supratemporal branch retinal artery occlusion. It is seen in a vaccinated person, not an infected person. Next is this PAM, paracentral acute middle maculopathy. It is actually the hypercoagulability which causes ischemia of small vessels, that is a deep retinal plexus. So what you can see is a paracentral area hyper-reflective of the reflectivity of the inner layers of the retina, and it can cause paracentral scotomas. Patient will have scotomas. It can be vaccine or infection related. Next is the acute macular neuroretinopathy. This is also ischemia of more deeper, that is choriocapillary layer. Patient will have hypopigmented wing-shaped areas in the foveal area, and patient will experience a paracentral scotoma and defective vision. And the octa shows, you can see the octa showing some areas of capillary non-vision in the choriocapillary layer. all the patients, all COVID patients need systemic steroids, so it can cause CSR. Fungal endophthalmitis, it is common in immunocompromised patients and also in diabetic patients. Next common virus is the dengue. Because of the thrombocytopenia, it can cause massive retinal hemorrhages. It can cause panuveitis-like picture or multifocal chorioretinitis, and usually the prognosis is good. Dengue is famous for the macular lesions. It can cause dengue maculopathy. It can be a macular hemorrhage, or it can be a diffuse or cystern macular edema, or it can produce a fovealitis, we call as AMN, or a PAM-like picture. Patient will have scotomas and defective vision. West Nile virus, not very common. It can cause multifocal chorioretinitis, and the diagnostic tool is that these chorioretinated patches are arranged in a radiating pattern from the disc along the nerve fiber layer. That is the diagnostic tool, and it can cause retinal vasculitis also. HIV, again, it can cause microangiopathy, which presents as cottonwool spots and hemorrhages. It can be associated with CME retinitis, and even the varicella zoster and HSV infection can be seen in HIV patients. Other viruses in children with SSP, that is subacute sclerosing panencephalitis, they may have retinal necrosis which affects the macular area. So the children will have defective vision. This may be the first sign of SSP also. Rubella virus, it affects the fetus in utero, and the child is born with salt and pepper retinopathy. Even adults can have a rubella virus infection. Chikungunya, it causes multifocal chorioretinitis, and it is treatable, and Zika virus also causes focal chorioretinitis. So these are some of the common lesions. Thank you for the patient hearing.
Thank you, Pappa, for that wonderful presentation. All the